Okay, good evening, everyone. Welcome to our second training event of the year. I'm Dr. Julie Tennille, Associate Professor of Social Work in the MSW program at Westchester University and Program Director for the fourth year of our Health Resources and Services Administration grant focused on interprofessional education and integrated care. We are presently in the process of responding to a new 4-year notice of funding opportunity from HRSA, so fingers crossed that we can continue this important work. I'd like to express an enormous debt of gratitude to the busy team behind the scenes, and this includes Dr. Cheryl Neal McFall, co-principal investigator and program evaluator, Wendy Myers, our amazing grant program coordinator, our fantastic research assistant, Sarah Fisher, and the amazing graduate assistant, Fatima Bakayoko. We are really excited about our 3 amazing presenters tonight, and I will introduce them momentarily. So this is part of a larger research study, and because of that, I want to provide a brief overview of the research and guide you through our informed consent and pretest. Also, because of the size of this audience, we will be taking questions for our speakers at the end of their presentations. So please enter your questions in the chat box throughout their talks. Fatima Bakayoko will be monitoring for themes to pose to our presenters toward the end of our time together tonight. The goal of this research and training grant is to expand numbers of MSW and MED school counseling professionals working with persons across the lifespan in vulnerable and medically underserved populations who can deliver evidence-based behavioral health services in southeastern Pennsylvania, Camden, New Jersey, and Wilmington, Delaware. Over these last 4 years, in a competitive application process, 116 students in their final practicum year have been awarded unrestricted $10,000 stipends. This funding has enabled some of our students to pay off credit card bills, car loans, or stop working part-time jobs, to enable them to focus more concertedly on absorbing knowledge and skills of working in integrated care as they prepare to enter the workforce. Additionally, these stipend recipients have been part of an extensive interprofessional training program that includes their field supervisors. Many of you are field supervisors on this event tonight. We're so grateful for you. All of our stipend recipients are attending 4 trainings over the course of the year, engaging in a practicum that adheres to integrated care standards and competencies, and taking a special elective on advanced clinical practice and integrated care. With over 25 affiliation agreements with community health partners, including schools in the region, this project is focused on long-term sustainability via an interprofessional network. And to that end, we have an Education and Programming for Integrated Care Regional Advisory Board of stakeholders. This advisory board is comprised of approximately 15 to 20 members from a variety of professions serving the region's medically underserved communities, and have steered us in the direction of fulfilling the values, mission, and vision of the board. One vision for the future includes working with our foundation and other university stakeholders to create a Westchester University Center for Integrated Care and to continue holding biannual symposiums. We had a successful symposium in the spring of 2019 and hope to hold another in fall of 2020.
Great. Thanks very much, Julie. I'm hoping that Andre, Travis, and I can provide some information that's useful in your careers, your work, your studies, and also a couple hours of distraction from watching the election returns, waiting for Pennsylvania to turn blue. So can we have the next slide? Yeah, I think it's important to take a national perspective on the current opioid epidemic. As Julie mentioned in her introduction, I've been working around treatment programs, mostly beginning with methadone treatment in the mid-70s. During the previous opioid epidemic. And I think it's important to know we never really ended the first epidemic. It waxes and wanes, it increases, but there's something different that's happened in the last 20 years, but mostly the last 10 years with regard to the frequency of opioid fatalities. And that's really given enormous visibility to the current opioid epidemic. And it's important to know that we've gone through phases since the late 90s of the epidemic being driven in the overdose mortality being driven by prescribed opioids initially in the 90s and the early 2000s. There was an increase of fatal overdoses attributable to more easily accessible heroin beginning in about 2010. And shortly after that, we started to see the incredible increase in overdose fatalities that are attributable to fentanyl and some of the other synthetic opioids. But in Philadelphia, it's become really a fentanyl epidemic. And that's what we're dealing with currently. The next slide. And this just shows you the national statistics on opioid fatalities and by the type of drug attributable to the death. You can see the purple line is the prescribed opioids, and it's kind of leveled off since about 2008 with the increasing in the last year, 2 years, decline. Physicians have become a bit more circumspect and less willing to prescribe large quantities of opioids to treat pain. I talked with some of the younger physicians that I work with and who went to school for medical school in the mid-90s, and they were taught that pain is like a vital sign, like to treat pain like blood pressure and other vital characteristics, and to treat it with medications that were thought to be safe and less likely to lead to addiction. These are the physicians who are taught this. We know that's completely incorrect strategy, and it's been proven incorrect by the large number of people who have become dependent based upon their initial prescriptions and the large number of overdoses. And so that trend in prescribing opioids has really declined, and there's really been a dramatic reduction in the number of prescribed opioids. But as you can see, with the in about 2010, the orange line, the yellow line, heroin was predominantly increasing in its as a cause of fatal overdoses. But shortly after that, within a couple of years, fentanyl, the dark black line that just spikes straight up, is has been responsible for the majority of overdose deaths, that are that account for the large increase. And as you can see, the overall opioid increase parallels the line for the synthetic opioids. So fentanyl really is responsible for this increasing and highly visible epidemic of opioid overdoses. The next slide. And we all know that Philadelphia's got a significant problem with opioids, but this slide puts it into context of using county data collected by the CDC. Philadelphia at the top of this column of cities. These are the 10 largest, the counties that are most closely connected with the 10 largest cities. Philadelphia, far exceeds the other cities in terms of the prevalence of opioid overdose deaths. These are the rates per uh, uh, per 100,000 residents, and you can see about 65 deaths per 100,000 in Philadelphia, compared to the next uh, uh, highest city of Chicago in Cook County. It's has about 1/3 the number of fatalities attributable to opioids. It's really a particularly significant problem in Philadelphia. You might ask, why is that? Well, one simple answer is the purity of heroin, this is the purity and the cost. The purity is the dark bars in this chart, and the red bars represent the cost. Philadelphia is above the arrow that's pointing up, the first column, the first bars on the far left. You can see it. We have the DEA attributes, tests the drugs that are confiscated and bought on the streets. We have the purest heroin in the country, and by the way, this has been true for quite a while. As long as I've been in Philadelphia, this has been one of its distinguishing characteristics. We've been #1 for a long time in terms of purity of heroin. And the cost is the cheapest. So it's a perfect marketing model for making it easy for people to feel the effects at a fairly low cost. Next slide. And this just is the local chart that kind of breaks out the various substances that are discovered by the medical examiner upon a fatal overdose. And you can see any opioid is the top bar. But if you look closely at the other lines, you'll see that fentanyl is present in nearly all of those fatalities, but also cocaine is the darker purple bar, and the red bar is heroin, green bar is benzodiazepines. And I think this slide points out that while these are classified as opioid overdose fatalities, most of the people have multiple substances that they use and that are present at the time of death. Next slide. Geography is important as well, and I think for those of you who are familiar with the city of Philadelphia, this is a map of the city, and I'm putting my cursor over the area with the highest concentration of non-fatal overdoses. And these are overdoses that are responded to, and obviously people have not died from these overdoses, but are reported by the fire department, the emergency medical services, the police department, which is the yellow dots, the fire department's emergency medical services are the red dots. SEPTA responses are the blue dots. You can see the L going across the city here, the Broad Street line going north and south. And Prevention Point, Philadelphia, those are reports of naloxone use by staff or clients of Prevention Point. So anyway, there are very large numbers of people who overdose and don't die from the overdose. We see this as hopefully an opportunity to intervene, to perhaps engage people in treatment. Although, as we'll talk about throughout the evening, that's an overly simplistic scenario. And next slide. And this is a heat map of the fatal overdoses, and it overlays pretty clearly with the non-fatal overdoses. You can see the darkest red area here represents the Kensington neighborhood, but it extends up into for a little bit further up into the northeast. The second highest area of concentration of fatal overdoses is the South Philadelphia area, which is clearly highlighted on the map here. But it's also important to mention, to note, and to be aware that fatal overdoses are happening in every neighborhood in the city. You know, while there are certainly concentrations of fatalities, there's no neighborhood that is without fatal overdoses and without without individuals living with opioid use disorder. The Mayor's Commission on the Opioid Epidemic a few years ago estimated that there are 120,000 people in Philadelphia living with opioid use disorder. So it's a huge problem here. And as Julie said, it's probably closer to 6 to 8% of the city's population, but that's a huge challenge for those of us who want to provide help to people who are struggling with opioid use disorder. The next slide. And if you want a little more detail on the characteristics of people that are overdosing, this is data from the 2 years of data, 2017, 2018. And as you can see, it's about 3 to 1 male individuals who are overdosing. These represent rates per 100,000 population. But it gives you a numerical estimate or numerical marker for the characteristics that are most strongly associated with fatal overdose. In these years, white, non-Hispanic individuals had the highest rate of fatal overdoses, and the age ranges beginning from 25 to 34, but really the highest concentrations are in the older age groups, 35 to 44, and the highest is 45 to 54-year-olds. Now these numbers have changed a little bit, and I'll talk about that in a short while. Importantly, in 2018, the total number of drug overdoses declined, but it's still, a significant epidemic and a significant public health problem in the city. And by comparison, you can see the homicide rate, which averages around, currently somewhere around 400 homicides per year. It's 1/3 the number of individuals who are died of overdose. And by the way, in 2019, the numbers increased slightly from 1,116 deaths to the next slide. To 1,150 total overdose deaths and this gives you a sense of the drugs that are involved. And again, you can see the total increase in the number of fatalities that are attributable to these substances. But it's really, again, important to recognize that In 2019, the bar on the furthest right on this chart, the largest concentration of fatalities occurred among people who were using opioids and stimulants at the time of their death. Probably speedball, probably fentanyl, either in the heroin or fentanyl in the cocaine, because now one of the things that is well documented is that fentanyl is being substituted in every type of drug that's being sold in the illicit drug market. But clearly, the people who are overdosing on opioids are using multiple substances, and stimulants, cocaine, methamphetamine are the most commonly co-occurring drugs. There were 164 deaths from among people who were using stimulants alone with no opioids present. And as I mentioned, some of the characteristics, we've started to see changes. Some of the characteristics in the people that are dying, and by change, I mean in the very recent data reports, we have, this shows the racial characteristics of fatal overdoses by month. And in 2020 are the kind of the foggy columns there because they're not the final numbers. But one of the disturbing trends is that the Black non-Hispanic individuals in the last 3 months of this chart had the highest number of fatal overdoses, which, as I mentioned earlier, it really represents a significant change. It's something that we have to be very concerned about, that the epidemic is shifting in terms of the population that may be most at risk. Now, so far I've talked about fatal overdoses, and I think, you know, it's a situation, another situation where the tip of the iceberg analogy is well suited. As I mentioned, there have been 963 fatal opioid overdoses in 2019, the last year. But as I mentioned also, 120,000 people are estimated to be to meet criteria for opioid use disorder. And these individuals have a wide range of health problems and social issues that they are struggling with because of their opioid use disorder. The next slide. From some of the co-occurring medical conditions that we've seen increases in Philadelphia, we see the rate of hepatitis C has paralleled the increase in the opioid epidemic. These are cases that will lead to significant public health morbidity and mortality. The blue or the green bars in the chart on the right represent individuals who are diagnosed with endocarditis, an extremely expensive and time dependent it takes a long time to cure an individual who's treated for endocarditis. And by the way, this is a hospital-based treatment, and you can imagine an individual who has an opioid use disorder and is diagnosed with endocarditis being placed in the hospital without much access to treatments or medications for the treatment of of their opioid use disorder. So it's a really challenging problem, a really expensive problem, and one that hospitals all over the city are struggling with. Next slide. COVID-19, as Julie mentioned in the introduction, before COVID-19, the opioid epidemic was considered by the local, by regional, by state, and by national public health officials, as well as other systems that have to deal with these individuals, as the number one public health challenge of our lifetime. Now we're dealing with COVID-19. And this is just 3 sets of bars here that are broken out by Black and Caucasian individuals. And the chart, or the bars on the far left here, show the mortality rate among the general population of people who are hospitalized due to COVID-19. These middle bars here represent, again, African Americans and Caucasians. The blue bars are African American, but who also have COVID-19, are hospitalized, but also have a substance use disorder. And in both the Blacks and whites, the rates of mortality are significantly higher. And certainly between the 2 groups, again, the differences, the racial disparities in terms of deaths attributable to COVID-19 are significant. The bar chart on the bars on the far right represent people with recent substance use disorder diagnosis. So again, COVID-19 for people with substance use disorder is a more significant health problem. Now, we've known for a while that injection drug use is associated with the transmission of HIV infection, and this shows data from 1981, when the first case of HIV was diagnosed in Philadelphia. This shows you the number of cases attributable to injection drug use. It peaked in 1995, and for the subsequent 25, 30 years has continued to decline. These red arrows just represent the introduction of the syringe exchange program in 1991, prevention point. Antiretroviral therapy was introduced, which can also reduce transmission in about 1996. Suboxone was approved by the FDA in 2004. And the methadone treatment slots expanded pretty significantly in Philadelphia, all contributing to a reduction in HIV transmission until the next slide, until the current opioid epidemic. This is a national map, by the way, obviously, but it shows you places where there have been outbreaks of HIV infection among people who inject drugs. And these are, for the most part, places that did not have an HIV problem prior to the opioid epidemic. But the opioid epidemic is a national problem, and along with it has come the more frequent transmission of HIV infection. The next slide. And this is the Philadelphia data for the last few years that shows a 151% increase in the number of new HIV infections since 2016. I showed you the chart that had 25 years of steady decline in cases. We thought we had this problem under control, but the prevalence of opioid use and injection has surged, and so has the HIV epidemic. The next slide, please. And in terms of other problems that are associated with the opioid epidemic, obviously homelessness and the Kensington area. This is a picture of, you can't see it very clearly, but the bottom left shows the encampments before they were cleaned out and removed. The city did a very good job, I thought, of trying to find alternative housing for folks. But ultimately, many of these people just were shifted to homeless situations in other parts of the neighborhood. But again, the city really did try hard to work with each individual to try to link them to services that they needed and to find housing. There just isn't enough housing for homeless people in the city, particularly homeless people who also have a substance use disorder. The next slide, please. Just to kind of reinforce the picture of the multiple problems that people are dealing with, we did a study not too long ago of recruiting people in Kensington, asking them to come into our mobile research unit and do some assessments to determine the severity of their opioid epidemic, their opioid use, which for 92% of the people we interviewed was severe. Opioid use disorder, according to DSM-5, can be categorized as mild, moderate, and severe. Most of the people that we interviewed met criteria for the severe diagnosis. 30% had experienced an overdose, opioid overdose in the past 6 months. 36% had received some medication-assisted treatment in the past 30 days, and 40% met criteria for severe or very severe depression. Next slide. Obviously, the first response of the city has been to try to expand the treatment capacity, and it's done that. This shows you the increase in the number of treatment slots for the blue bar. The blue portion of the bars represent buprenorphine, the orange methadone, and the red long-acting naltrexone. So the treatment response has been the most common recommendation by individuals trying to respond to the opioid epidemic. Lots of money has been devoted to expanding treatment access in the existing structure of treatment. But as you can see in the next slide, I believe, Julie, still, 23% in 2018 of the treatment slots went unused. So this is like a huge contradiction in my view of things, because we have this unused treatment capacity in the city with the highest proportion of people with opioid use disorder in the country, and we can't seem to get people to engage in the treatment that we have available. This is the theme that we will be talking about for the rest of the presentation. Other countries, as you'll see on the next slide, this is a slide showing some of the European countries. Down here is the United States. We estimate there's somewhere around 13% of people with substance use disorder are actually receiving treatment. In these countries, we're somewhere between Latvia and Poland in terms of the rates. But there are countries, and this is France, and where nearly 80% of the people with a diagnosed substance use disorder are connected to a treatment program. So it is possible for countries, for cities, for communities to engage significantly more people in treatment. But currently, our structures are not meeting that challenge. Next slide. So we designed this, in an effort to address this this gap in treatment utilization, thinking that what if, the goal of this Project Reid, is the rapid initiation of buprenorphine and naloxone to optimize MAT in Philadelphia. It's a CDC funded study. We use our mobile unit. We take treatment to the communities. We've targeted 2 communities. Based upon the concentration of overdose fatalities in South Philadelphia and in Kensington. And we have the next slide will give you a little bit of overview of the structure of what we're trying to do here. The goal is really to rapidly relieve withdrawal symptoms. We think that that is a critically important factor in helping people to make a decision to get into the treatment that's right for them. So we're mobile. We first focus on as soon as possible, and that's usually within a day, getting medication to the person to control the withdrawal symptoms, and then begin working with them for a 3-month period to connect them with the provider that's best for that meets the needs of that individual. We'll provide the medication. We bring it to the participant on the mobile unit, and we have a nurse practitioner, a case manager, and a peer recovery specialist who work with the individual to help them identify the treatment program that's going to have the best chance of helping them. As I mentioned, we're targeting these 2 neighborhoods with the highest concentration of opioid fatalities and overdoses. Next slide. So anyway, for this portion of the talk, the points are pretty simple, really, that we're experiencing a severe opioid epidemic, that there are both biological and social impacts of the epidemic. But perhaps most importantly, we really need to develop new strategies for engaging people in evidence-based treatment, which for opioid use disorder are medication-assisted treatments. And I think Travis will be talking in a bit more detail about those issues.
Thank you so much, David. We really, really appreciate your knowledge and experience. And at this time, I will ask Travis to unmute himself. And let me just introduce you for a moment or 2 before you can get started. So Travis Cause, Dr. Travis Cause is a health psychologist in integrated primary care at the Corporeal Michael Crescens Philadelphia VA Medical Center. I probably completely butchered that name, but the VA Medical Center in Philly. He has experience working with medication-assisted treatment and substance use from a clinical and research perspective in community settings and expertise in integrated primary care. So I'm delighted to turn it over to you, Travis.
Well, I'm so glad to be here tonight. Thank you for letting me join. And I want to just first start to say, is I know we're working with a broad catchment area. While the numbers are readily producible about Philadelphia, Camden, Wilmington, and the surrounding areas are all interconnected. We have plenty of people that drive in from Western Pennsylvania, from down the coast in Delaware, through Jersey to come into Philadelphia to obtain heroin or fentanyl. So there is definitely a combination in things that get shipped into Philadelphia or the area get spread across this local area. While there's a lot of concentration in Philadelphia proper, this is not just a Philadelphia problem, as Dr. Metzger said. And just to note that one of the largest fentanyl shipments that have been seized in this country was seized in Wilmington, Delaware. So this is a pretty wide-based issue, and I just want to kind of keep that lens there as we're talking. So as we go on to the next slide, I just want to give a little bit of perspective. I spend a good amount of my time each week, probably about 20%, thinking and helping new clinicians who are coming into the field, as well as students in graduate programs, and thinking What do you need to know? And of course, you think back to yourself of what did you know at that point and what did you wish you knew when you were studying or starting this? But also reflecting of kind of the times and where some of the challenges are. And I think one of the biggest misnomers that was given to me, and not intentionally, I don't think directly, was, oh, I'm going into clinical practice. Someone else will handle substance use. You don't need to focus on substance use. If you're going to be in private practice or doing some community practice, let me get my Jeopardy buzzer the loudest I can and go, that is not true. Whenever you're working with anyone, there's a potential for substance use to come into play in a lot of different forms. And I imagine through your practicum experiences, you've been coming across that, or from other clinical experiences that you may have had. One thing that is very true, and I'll try to slip into some of the comments that came up in the chat feed while Dr. Metzger was talking, was this notion that there are a lot of factors of why people turn to opioid use disorder. We know one factor is, sure, someone that did go through some pain, maybe receive some opioids as far as their pain treatment, that acute pain doesn't go away, they persist on the opioids, it gets harder and harder to get the opioids from a provider, they start to doctor shop, provider shop, and then they find it's just easier to go out on the street, and those costs get really expensive. Pills can run hundreds of dollars or more to be able to obtain. All of a sudden, there's some ambivalence to going to heroin or fentanyl, and then someone says, it's so cheap, just try this. It's so much cheaper than what you're paying for. And then they cross that Rubicon. And that's some of the people that do wind up using heroin or fentanyl. But we know comorbidity is such a huge factor. And one of the biggest factors is a lot of people are experiencing a lot of acute distress in their life. We see that 52 to 60% of people who have an opioid use disorder have a lifetime history of anxiety disorder. And for most of those individuals, that anxiety was well present, often starting in grade school, teen years, and moving up into their 20s and getting more and more intense. So it predates opioid use for most individuals, particularly experience of post-traumatic stress disorder, panic disorder, generalized anxiety disorder, as well as things like social anxiety and specific phobia, which we often don't catch enough in our clinical practices. I've met with so many people who say, I had social anxiety and I was trying to seek a way out of my bubble. I was just trying to level out. I was trying not to always be anxious. And I found some pills, or I started drinking, and then that wasn't enough, or I didn't want to become addicted to alcohol. So I said, let me try some pills. And they found themselves using opioids as a way to cope. Same thing with depression, that over 50% to nearly 100% have some history of a depressive disorder, dysthymia, major depression, persistent depressive disorder, the various bipolar disorders. They co-occur at a high degree. And this will make a little bit more sense when I talk about opioids and what opioids really do in one moment. We also know that adverse childhood events are very common. And the more we know that 1+ ACE is common in most Americans. And as we move up and up and up, as we get closer to 4 ACEs, well, there's higher rates of health complications as well as substance use. And when we're in a chronic, stressful environment, it's hard to escape that. That can trigger more PTSD, more anxiety, more depression. And then we know that act in pursuit of something like heroin, opioid use, fentanyl, that's pricey. That can put us in very high-risk situations. That can put us under a lot of stress, involvement in the legal system, the sex trade, various sorts of interactions with people that may not be very positive, and that can further kick up anxiety and depression when we move away from our purpose-driven activities that used to maybe guide us in some way to where our life becomes more and more focused about obtaining, using, and recovering from opioids. So that can really take over the things that were once enjoyable as we're just trying to survive and not get sick. So one quick thing before we move on to the next slide is if any of you have had a surgery, gone to the dentist and got an opioid, you know that calms you down. You might have gotten a little euphoria or joy, and it maybe helped you sleep or kind of zonk out or remove yourself from the pain. Maybe some of you have got that very elusive runner's high where you had our natural opioids kind of give you this little bit of a feeling of up and kind of this like sense of peace. Well, if you have all these things on this page, you're probably looking for some relief. And therefore you may pursue these things, but then as a vicious cycle of being kind of getting trapped away from your priorities, these different conditions can come up much louder in more adverse circumstances. So as we move on to the next slide, we know that just to speak to opioid use disorder and overdose, well, opioids help slow down our processes of kind of calming our mind, providing joy, kicking in more of our parasympathetic nervous system instead of our fight, flight, or freeze. So what happens is it slows down our breathing, it slows down our heart rate, it slows down some of our non-critical functioning. It can slow down our awareness and concentration. And in extremely high, especially fentanyl, that may well exceed what our tolerance of what our body can take in processing those neurotransmitters, all of a sudden sends our body into a crash where that parasympathetic nervous system kicks over, and our sympathetic nervous system shuts down. So all of a sudden, we're not able to breathe. We're not able to come out of a alertness to realize I'm not breathing, I'm not functioning. And that's where people can go into an overdose situation. So that just helps understand what an overdose is. So where does opioid use disorder appear? Well, it can appear in a hospital. It can appear in someone having that motivation to go to a substance use treatment and say, hey, I have a dual diagnosis. I want to get help for this. Or just realizing I have a lot of distress. I want to get help for my substance use. But where else can we see it? We can see it in schools. We can see someone starting to experiment with pills at an early age, whether it's whatever's in the cabinet of whatever they can get from family. Maybe it was their own medication that they're on that they're now overusing. We can see this come up in shelter-based settings where someone may be getting residential care and you might be providing your practicum or support there, and you realize that someone's really going through a lot of adverse circumstances in their life and they're trying to cope in this way, and they have a history of opioid use disorder. We can also see this in outpatient primary behavioral health practices. When you're working with someone, you might find that they are maybe overusing opioids in some way or periodically using opioids to escape or getting caught in the addiction cycle. And it doesn't come until you've gotten to see them because they're coming for anxiety or trauma or depression. And then one of the great areas that we can do this intervention is integrated primary care. And most people seek out at some point a health provider for care. And I am a big advocate and a big supporter of integration because it's the way that's the great equalizer. We all eventually need a sick visit, a physical, and through effective screening and hotspotting individuals that might be having various challenges, we can get them to a behavioral health provider that can really make a difference. So as we go on, we know that opioid use disorders are going to lead to more complications. We heard about HIV, hepatitis C, cardiac conditions, but this also can lead to cysts. It can lead to abscesses. It can lead to affecting the immune system where someone may be sick. So as we go on to the next slide, integrated primary care is awesome. I love it. It is on the vanguard of a way that we deliver care. I've not been practicing in this for 10 plus years just because it was a job. It's really a calling to me. And when we work in primary care, we're meeting the community where the community's at. And instead of old models where we had to say that still exist and are really great, hey, I got someone here who would benefit from treatment. Mind if I send them across town for a referral? Well, the research shows these referrals, the modal number of visits is 1. People often come for the intake and don't come back. Well, what if we can bring care to them, right where they are, in their communities where they live? One option is integrated primary care, where in pre-COVID times, and COVID times is a little bit more funkier, you're co-located in the office, you directly communicate back and forth with the healthcare team, and you collaborate on various different conditions. So for example, when I was in one of my health centers, I was involved in every hepatitis C case that we were seeking treatment. I would do an assessment, I would meet with them to see what barriers might exist for hepatitis C, and is there any substance use actively going on? Would you be interested in getting some medication or some treatment for that? I know my esteemed colleague, Andre, will also be getting into some ways to help engage people, but I'll touch briefly on that as we move on to the next slide. One thing that these two small disease slides tell you is that over 2/3 of primary care organizations are in some way integrating behavioral health into it. And of those that aren't, most are looking to find a way to get behavioral health into primary care. We see it as a really great way to begin to offer brief levels of care. You're not seeing someone for years and years on end, week after week, but you're mimicking your visit to what a provider does. A health provider sees someone for 15 to 30 minutes. So we're seeing people in very short episodic episodes of care where you might see someone for 1 to 4 to 8 visits, and then you might catch up with them again in their life as different things change, as things occur. So it's an excellent spot to work as a team, to really reach people that would not otherwise access the substance use or mental health system. And we can do some great motivational work, try to address what stressors are in their life, and help increase their readiness to access care. Or there may be the provision of care in your health setting where you can get someone started on an opioid replacement approach. And one thing I just want to stress as being an alumni of the HRSA Health Services Corp, this is a great way to get some of those educational loans repaid by going to a participating health center, usually federally qualified health centers, community health centers, there's a range of them as well, and committing a certain amount of time, they can repay back parts of your loan, as you can see here, for full-time and part-time work. So these are just amazing programs. We really need to get more and more effective clinicians into settings where we can help the community. And this is a way that we can do it through these loan repayment programs in Philadelphia, Camden, Delaware, but also all across the country. There are so many places that just do not have great access to behavioral health care, and we can do so much by helping decrease those disparities. So as we move on, I just want to talk about this magical thing called MAT, medication-assisted treatment. You might also see this called medications for opioid use disorder, MOUD. And often these medications are done in conjunction with other forms of treatment. But what they do is they help someone get off that roller coaster and that wheel of opioid use disorder by addressing cravings and what the body is doing to further claim to want more opioids, to deal with the gap. What happens is we have natural opioid receptors in our brain, represented by these little Ys that you see. And the neurotransmitters in our brain release opioids, both in relation to stress, in relations to exercise, to sex, to gambling, to pleasurable things. When you kind of see that like on Facebook or Snapchat, you're like, oh, someone was looking at my post, releases endorphic opioids. Well, if we add more opioids to the mix, whoa, we get a surge and we get this euphoria and those feelings that people feel from the use of opioids. But what happens is the brain's like, we're not gonna let that free ride stop. Because there's such a surge of opioids in the brain, it says, let's make more receptors or more parking spots for opioids to go into. So what happens is there's more parking spots that say, hey, where's my opioids? I haven't got that little rush in a little while. And therefore, your brain can't ramp up and produce more opioids. So those parking lots start screaming out and saying, hey, give me. I don't have opioids right now. And then once we get to this dependence level where more of these parking spots or receptors are, we then seek the opioids because we start having those nasty withdrawal symptoms, the feeling sick, the shaky, really anxious, the GI distress, all the things that come with it if you've seen anyone going through this or talked to anyone through it. And what we want to do is not have that euphoria and kind of knock out and put someone in those really difficult circumstances where theft, illegal activities, risk for harm to themselves, overdose occurs. But we want to get them a medication that will meet that craving, but allow them to function. This is not drug replacement in a way of let's trade one drug for another. This is a way to effectively treat someone. So there's 3 different categories that we commonly see for opioid use. There's also some for alcohol and some with a little bit less efficacy for other drugs, but I'll focus on those for opioids. Methadone it doesn't get as much of the credit as it really deserves, but it really changed the game with heroin and opioids. And it's an agonist. So what it means is it actually sits in the receptor and works as a synthetic opioid, very similar to other opioids like heroin or oxycodone or fentanyl. But the thing is, it is very slow release. So that extended release keeps that receptor occupied and stops those craving symptoms while allowing that person to function. And when the dose is matched right, that person can function fully in society, and therapy and other supports can help them get out of that cycle of what addiction brings and get back to life. On the other extreme is buprenorphine, and that works as an antagonist. And think about if you've ever been to a parking lot where it says how many spots are still available. There's a little sensor to say how many spots are open or not. I'm sorry, I'm going over to naltrexone. I'm looking at the far right. Naltrexone acts to say, to kind of trick those cravings, to say, hey, there's something here, and it blocks, it knocks away any opioids that come in. So if you try to use opioids at a modest dose with naltrexone, it wouldn't process. You wouldn't get that high feeling. It works the same way with alcohol. It doesn't create that kind of inebriated feeling, that buzz. Now, a risk with naltrexone is too much, and it can actually override that blocker, that whether it's a pill or shot like Vivitrol that someone might receive. It is really recommended for those that are, have gone through a little bit of treatment or trying to stop. And then, with opioids, you need to get it out of your system because it can cause what we call precipitated withdrawal if you take it before the opioids that you were using are out of your system. But it can really block the effect of the drug and help someone out. In the middle is Suboxone, or I always struggle to say this in a public setting, so Buprenorphine. And if I go fast, I screw it up. So with Buprenorphine, what it does is it acts as a combination of both. It's a partial agonist, so it sort of works like an opioid, but it's also a blocker. So it kind of is like, it's sort of in the parking lot. It's like almost if you put like an inflatable car in that parking spot where it's blocked, another car can't park there, but it's also just barely touching the receptors, not like a full heroin or fentanyl would. So it helps take care of both the cravings, and it also blocks if you try to use. So that's very effective because methadone has a lot of restrictions and can only be offered in a lot of substance use settings that have a special license. But Suboxone, naltrexone can be offered in a range of settings, including primary care. So this is a way we're flattening the curve and helping have people have better access where they can't get to a treatment facility, or there's too much stigma for them, or they have a conversation in primary care and say, yeah, I'd be willing to give this a try. If they meet certain criteria, they can start this medication. So as we go on to the next slide.
So Travis, I just have to let you know that you've got 2 minutes.
Okay, I'll be really quick. Thank you so
Thanks.
much. So these medicines reduce cravings. They treat, they block subsequent drugs. They can help prevent overdose, and they can help someone return to normal functioning. But they don't get people high. They don't impair functioning when people are able to kind of get situated on those medications, and it's not one exchange of one drug for the other. So if I move real quick to the next slide, first I just want to make a pitch. Naloxone, Narcan, it's so important to carry that. You can save a life. I've seen it being done. It is a great way to reverse. It helps kick out the opioids out of the system and is a great way to kind of hold someone on until they can get emergency care, or if they're going into an overdose to save life. And so Dr. Metzger talked about how we're integrating opioid treatment into the community through having mobile access vans where someone can walk up, express interest, and we can start them nearly right away on a MAT treatment, notably often Suboxone or a variant of that, buprenorphine. So as we go on to the next slide, let me go full circle to end this. We know dual diagnosis, triple diagnosis comes with this. So one thing that we're doing is we've created a tool called the Match, which asks a number of quick questions to ask about mental health, access to primary care, stressors in life. In a matter of moments, we can screen some of those needs. So when we go to the next slide, we can give a list of, we're going to start you on this treatment and work with you for a little bit, but we can access you to a primary care center that's offering MAT, or a substance use treatment center, or maybe you just want behavioral health alone. Here's for South Philly, here's a couple options right near you that we can get to you. So this is a tool that we've been piloting and trying to refine, and Dr. Metzger has plans to use this in a wider study that we'll be launching soon as a way to quickly screen and help people get to the care they need, in addition to getting the MAT that might be helpful. And as I end on our final slide here, I just want to talk about motivation to change real quick. Stages of change is always crucial to think about. Just because someone's in a pre-contemplation stage and not ready to change doesn't mean that they're not processing this information of, I understand heroin's part of your life. I understand it has a lot of benefits for you right now with some of the pain and what you're dealing. There are treatments. If you ever want to come back, we're here. People cycle through these different stages and it's not always linear. Someone might be pre-contemplating when something scary happens, an overdose, they're in the action stage. Or maybe they're in action and maintenance for a while and then something happens and it knocks them out of treatment. But then they can enter at any stage of this. And through work and support and using motivational interviewing and kindness, we can often help someone think about what they want to do and help get access to care, which I think is a great way to set up my colleague, Andre Reid.
Thank you, Travis, for your excellent presentation. Very much appreciated. All right, so Andre, I'd like for you to unmute yourself while I introduce you. So Andre Reid created Philadelphia's National Alliance of Medication-Assisted Recovery in 2014 to advocate for the expansion of MAT for people from diverse communities who live and are affected by the opioid epidemic. His knowledge, obtained through working at Philadelphia's Office of Addiction Services, combined with his own lived experiences, have provided the expertise to share awareness of the lack of equity of healthcare, socioeconomic benefits, and community supports for underserved citizens of Philadelphia. Andre is currently a community consultant for the Philadelphia Department of Behavioral Health, CBH, and Intellectual Disabilities. He also serves as a reviewer of peer and integrated care standards for CBH's Network Improvement and Accountability Collaborative. Andre created and leads a consulting firm called Lived Experience Consultants. Andre is currently contracted through SAMHSA to conduct trainings for the Mid-Atlantic Region Addiction Technology Transfer Center Network Opioid Response Center. And I'll now turn this presentation over to Andre.
Thank you, Julie. I just want to say thank you to Dr. Metzger and Travis for allowing, and all the participants that's available inside this training. I just think it's very important at this time we're dealing with COVID-19 and we're looking at the opioid epidemic, that the opioid epidemic got put on the back burner. And a lot of people started focusing on COVID. And I remember looking at the news, and I remember going real strong at the beginning of the COVID epidemic in January, February, and then nobody talked about the opioid epidemic anymore, substance use disorder, opioid epidemic. And when I ride through Kensington now, you can see when you turn an eye away from this real social dilemma, how bad it gets again. You can go to the next one. So my focus really is opioid epidemic, medically assisted treatment, but then I also look how it affects the community. And I can look at community of color. I look at underserved communities, not just Kensington, West Philly, South Philly, Southwest Philly, North Philly, urban community. Young Black men right now are using Percocets at a real high rate. And we're really not addressing that. So we're looking at all these communities that's being underserved because everybody think the epicenter of the opioid epidemic is only Kensington. And when you talk about integrated care, I'm only talking to this, the people who are going to go out there and work in the service. Integrated care is trying to connect all these services so we can start dealing with the social determination of health issues that people have. So you're going to be dealing with education, health disparities, homelessness. So when we're looking at all these services, how do I connect this individual that when I walked into a program, and I'm in recovery myself, when I walked into a program, I walked in there with not only an opioid use disorder, I walked in there with a lot of other issues. I was homeless. I had no employment. So it was other social issues that was going on that helped drive my use for opiates. So providing integrated care helps patients and their providers. It blends the expertise of mental health, substance use, and primary care clinicians with feedback from patients and their caregivers. This creates a team-based approach where mental health care and general medical care are offered in the same setting. I think lived experience is very crucial right now to this opioid epidemic that we're dealing with and all this social crises that we have. My first time working on a case manager, I worked on a case management team that we had someone work with. We had we had an employment clinician, we had a homeless clinician, we had a certified addictions counselor, and we worked as a team with the psychiatrist that we provided a comprehensive care approach towards the participant, getting them the services that they need. So I think that is really having a comprehensive approach towards not only do we look at the drug and alcohol, the substance use disorder, or the opiate use disorder, we start looking at other disparities and ill effects that can affect a person's life. Recent research points to the value of a holistic approach to opiate recovery delivered in a community setting. Such an approach may include relapse prevention, medications, group and individual counseling, physicians' visits for medication management, mental health therapy, psychiatric treatment for co-occurring disorders, but there are barriers to assessing holistic opiate recovery treatment within the patient's community, such as lack of mental health resources, stigma associated with certain treatment options, limited availability to specialized providers, difficulty navigating complexities of substance use treatment, and insufficient capacity. We even see this in integrated care. So when you looking at integrated care and you look at that participant, member, patient, however you want to, call them, some communities going to bring different challenges. So if a person's coming out of a certain community, you might see that he has a stigma towards using methadone. Methadone is highly stigmatized. So a lot of people coming out the opiate use world will not use methadone, not because we know it's the gold standard for treatment. We know buprenorphine works, Suboxone. We know these work, but when you dealing with that person in that culture, it's a real funny culture that people who utilize opiates, heroin, they feel that methadone is somehow copping out. So we start seeing the challenges with getting a person who's living a destructive life of opiate use disorder, and how do you cross the bridge and get them into a methadone program, a Suboxone program, a buprenorphine, and a Naltrexone program. There's a lot of issues that affect them. But if they homeless, have no employment, dealing with a whole lot of health disparities, so when you're looking at that, it's a lot of issues that are going to be taking place when you walking a person through this whole process. And this is what I really look at a lot. And not only am I looking at it, you're starting to hear it looked at a lot and talked about a lot from social determinants of population health. Why are Black people sicker? Why do they die earlier than other racial groups? Many factors likely contribute to the increased morbidity and mortality among Black people. It's undeniable, though, that one of those factors is the care that they receive from their providers. Black people simply are not receiving the same quality of health care that white counterparts receive. And in the second-rate health care is the shortening of their lives. The argument can be said, Dr. Metzger talked about it, that I'm from Baltimore. Heroin just didn't show up. Heroin was devastating Baltimore. That's why a lot of people see The Wire and you see is nothing about drug dealing. That's the lifestyle that I seen back in the 80s and 90s in Baltimore. Overdose, people catching HIV and AIDS. That was all taking place right, and here go the funny thing about it. It was all taking place right down the street from Johns Hopkins Hospital. So why now do we see this great march to providing opiate use disorder, medically assisted treatment, and all the care that's getting placed in it? And I'm not going to make that determination. I know probably a lot of people with smarter brains than me to come to that conclusion. But I know one thing, the service mechanism and the service delivery standards has changed because of the overdose rates we see in other communities. So when I'm looking at it, when I'm talking to my team, when I'm going out and do presentations, one of my major focus is we have to deal with the opioid use disorder and substance use disorder, but we have to deal with what affects a person's whole life. So when that participant walks into your program and he's receiving services, what else is there for them? What else is left for them? Because if they leave your program and going back to the streets, if they leave your program and can't provide services pay for their own rent, if they're not getting proper care for diabetes, hypertension, obesity, so we have to look at the person in a whole realm and provide education. I'm in your program. I'm getting clean. I'm dealing with my opioid use disorder, but I don't have a GED. So I look at the whole realm of a person's treatment. I'm an outlier, I call myself sometimes. I did, when I got in treatment, I did go back to college and get a degree. I did go back and bought a home. I did all the things that, we do in recovery, we do in the world. But when I deal with my counterparts on the recovery side, not my colleagues from the office, where I deal with my colleagues from the lifestyle that I came from, a lot of them haven't even touched bases with a lot of these things. So, now we seeing departments talk about social determinants of population health. We seeing now diversity and equities with candidates running for office. But it's always been there. And I'm just going to say this so I go to the next slide. When that person come in your program, you're trying to get them clean, you got to do more than just try to get them clean. Their life is encompassed more than just that. And in order for them, we want to see them enjoy the quality of life the same way that I sit across them and provide the services. I want them to have the same quality of life. And if I don't tell them about these important factors, then their life probably won't be the same as mine. And here are the factors of social determinants. And this all the things that it affects. It affects employment, source of income, expenses, debt, bad credit, medical bills, and just supports you have, around you. It affects the environment, your housing, transportation. Transportation is a great issue to look at. I remember one time there was only 5 methadone programs in the city. So if you lived in West Philly, you could probably have to catch a bus way up to North Philly to the net, where it might have took you 2 or 3 hours to get to services. So when we see an integrated care, we see with integrated care is more access to care, and you start seeing it in language like federally qualified health centers. Federally qualified health centers are trying to do what one of the major models of integrated care, because we're trying to do it all in that one place. We're trying to provide all these services in that one place. And I'm not going to read all of them, but the quality of food in the community. So we see the quality of food is a connection to the expenses, with connection to socioeconomical issues that deal with a person. So that community that the person comes from is affected by all these things, can have a direct outcome on health disparities. And here we go. When we're looking at that person, a substance use disorder, mental health disorder, most of them are dealing with this: unemployment, lack of affordable housing, mental health issues, intellectual disabilities issues, substance abuse issues, access to services. A lot of them don't even know how to get the services. A lot of them don't even know what it means to go and walk into a program. A lot of them need services. I remember when Encampment was down there, and I was working with a program, a research project, and we took the treatment down to the encampment. I knew that them people in that encampment wasn't coming out of Kensington and walked to no program. But when I went down there and offered them services, a lot of them partaked in the services, access to services. But how far do we go to provide access to these services? How far do we bridge the gap? It's easy to say access to services, but how far do we bridge the gap? Low paying jobs. A person works and want to see an income that's going to provide them a quality of life that everyone else has. So, and family disputes and family issues. One of the major focuses that I seen in the medically assisted treatment program, family members had a greater outcome on a person's receiving methadone than their own doctor. So a boyfriend or a girlfriend or a mother or father could tell their son, their daughter, their husband or their wife, I don't want you to go to that program. and the doctor could talk to them and tell them, please don't go. But the family member, I've seen many family members talk a family member from receiving the care they need that can save their life. Physical and psychological reliance on opiates, a substance found in certain prescription pain medications and illegal drugs like heroin, allow human beings to develop opiate use disorder. And the reason I put that in, that we've seen the proliferation of pain medications, and the proliferation of pain medications back in around 2008, 2010, and it started coming in certain communities. And I remember when it started piquing my ear when they was calling it hillbilly heroin. And when we look at the research, we can see that some things happen in communities that was already happening in the inner cities, but they start happening in certain communities. So in suburban and rural communities where you see factories shut down, where you see loss of jobs, where you see all these things take place, you've seen the opiate rate go up. So what was happening was these communities were mirroring what was happening in the cities for numerous years. Loss of hope, loss of opportunity, loss of access to care. Because when people have a good blue collar job, they have good health insurance. You lose your blue collar job, you have no more health insurance. Now you can't go to the doctor as fast as you. When I grew up, my pop worked at Lockheed Martin, true story. I always stayed in the doctor. Andre, you got a dentist appointment. My mom always was taking us because we had good health care. Now, if my father factory would have shut down and I was in a rural or urban community, who knows what would have happened? My access to care would have shut down. So it was a book recently out where the two authors went and did research, and they showed that these rural communities, suburban communities, was showing the same thing that urban communities showed, and they seen the opiate rate go up. And when a factory would shut down in some of these communities, you would see the opiate rate rise because loss of hope. Health and healthcare disparities refer to differences in healthcare between the groups that are closely linked with socioeconomical and environmental disadvantages. Disparities occur across many dimensions, including race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. Going out there providing services, integrated care. How do you tell a 60-year-old mother that's addicted to opiates to get help? It's happening. I look at the research, I can tell you, New York had 70%, man, Kevin Howard did a study on this, training on this. We've seen in New York that New York has 78% overdoses, accidental overdoses for people over 55 and 65 that was prescribed pain medication. So we're looking at age disparities. We're looking at disabilities. We're looking at a lot of these disparities associated with opiate use disorder. And then you're dealing with opiate use disorder, you have AIDS, you have a lot of other issues. Now you have obstacles to care because of socioeconomic status and so other issues that affect the community and what we live. Oh my God. This basically talks about lived experience. And as I coming out of a lot of places for my job, working outside on research and projects, I see that at the table, it's a need for people who have walked this road to start having a more prevalent voice, a more powerful voice in what is provided to people. I appreciate everyone. I don't challenge people's knowledge because I think the help is going to come from everybody. Research, experts, medical, but lived experience is a necessary service that's going to be really utilized moving forward to provide the care that's going to be able to start linking people to services that are going to help transform their lives. Recovery-oriented mental health services values to respect and draw upon the lived experience of mental health and substance use disorders, issues, and consumers, their families and friends, staff, and the local communities. Core principles of this is lived experience of substance use disorder, mental health, and consumers, their family, friends, and staff, and the local communities is valued and respected. Recovery-oriented mental health and substance use service provide meaningful roles and positions, including leadership positions for people with lived experience of mental health issues and mental illness and substance use disorder, either personally or in the family or significant relationships. Organizational culture supports empowerment staff with lived experience in mental health issues to draw on that experience when responding to the people who use their services. We see certified peer specialists, certified recovery specialists. We see recovery coaches. We see all these terms that were already there. What's the funny thing about them is you would think that lived experience is a new thing, but when you look at the Hazleton Clinic and all those clinics and stuff, when they started all this stuff, they was already started from a lived experience approach. So, you know, incorporating lived experience with these services that you utilize and providing that connection when a person enters into treatment, enter into an integrated care service, access to care when a person comes in and can talk to someone or have a connection with someone who may have walked the road that they walk, it shortens the gap. So, and it provides expertise to people who may study it, review it, but never lived it. And when you lived it and you come back to provide the services for it, it's totally different.
So Andre, we are at the end of our time.
Thank you.
We could listen for hours to the three of you, but I'd love to have an opportunity to turn this over to the audience and see what questions they might have for each of you. But thank you so much for your expertise. Okay, so at this point, I'm going to turn this over to Fatima Bakayoko, who's been kind of curating the chat and has some questions to pose to Andre and to David and to Travis.
So the first question is for Dr. Metzger. Given the number of deaths due to drugs in the city, what are your thoughts on the city's recent creation of a smoking ban in inpatient treatment facilities? You're still on mute.
Yeah, unmute yourself, Dave.
Yeah, I should know by now. You know, for a long time now, treatment programs have been restricting smoking. And, you know, it's one of these issues that people have used to view as a barrier to getting into treatment. I think there are you know, most programs now, most residential programs don't allow smoking, but they might have restricted areas where you are able to. Travis may know more about or Andre may know more about the current policies for smoking, but you know, I think we have to promote the health of people, and certainly smoking is not a healthy thing to be doing. So I support smoking bans, but recognize that there are strategies that can be used to allow some people to smoke.
Also, the smoking, you know, it was time that was permitted to services. You had to take them out for smoke breaks. So it was a lot of other time that could utilize to more positive time for their recovery. And then the people who worked as staff that didn't smoke had to be subjected to people smoking around them. So, and then like Dr. Metzger says, you're starting to begin to have a person start a healthy lifestyle. So that's the first approach when a person comes into treatment. The first healthy commitment they can have is to stop, you know, smoking.
You know, can I ask a follow-up question to Travis, though, on this topic? This is something that's come up a number of times in our graduate program. And Travis, I feel like you know, really kind of hone in on that modal number of, you know, one time that you got one shot to engage this person and to get them to, you know, kind of connect with you. And I'd love to hear your thoughts on, smoking bans and, in relationship to that sort of harm reduction approach.
Yeah, I think Andre made a really great point that you're not just dealing with opioid use disorder. A person brings their whole life, their whole experience. And for someone, smoking might be a way that they cope every day, or it's just become a big part of their life. I have definitely come across some people of like, yeah, I'd like to go inpatient, but I don't want to not smoke. It's not everyone, but it can be quite a challenge. I think when we think about harm reduction, though, we're not just talking use or not use. We're talking a range of things of what is someone comfortable doing at this stage. For someone, it might be I want to use opioids safer, so I want to be able to do a needle exchange and have that. For someone, it might be I want to reduce smoking. I don't know if I want to fully stop, or I want to find a way to do that. So I think this is always person-centered and having a conversation. And sometimes that motivation of, well, I don't know if I'm going to quit smoking for the long term, but I know I'm risking my life if I stay out here, keep using opioids. It's hit my life in a number of ways. So I can potentially give up smoking for that month if it's going to help me get some treatment and get on the right path. So that's just some of the conversations I've had, is just kind of weighing that decisional balance of what is the bigger risk here? What's the hardest thing for you? And then trying to find something that fits with someone's values and their direction in life where they're trying to go.
Okay, thank you. So Dr. Kaz, this question is for you. Could you speak to the risk of overdose with any of the MAT medications if other substances are used on top of them?
I think I actually feel most comfortable kicking to my other two panelists who are a little bit better versed in the day-to-day of those, but there are risks, and I will defer that to my two colleagues.
Depends on what substances are being used in addition to the treatment medications. For opioids, there is, as Travis said, a protective effect from buprenorphine and to a certain extent methadone. But certainly for naltrexone, there's all, it's very difficult to overdose on opioids. But, they don't, these opioid medications don't affect cocaine or other stimulants that are also associated with serious consequences. Obviously, the goal is to stop using all substances when you're committed to treatment, when you're in treatment. But we know that opioid users who are in methadone treatment, probably 30 to 40% of the time, have other substances in their system, sometimes opioids. But it's much safer to be on these medications than to not be on these medications and using the same drugs.
I can quickly add that benzodiazepines can be a risk factor too.
Yeah.
There's some cross tolerance with those too.
Yeah, for sure.
Okay, thank you. So Dr. Metzger, this is for you. How are the peer recovery specialists credentialed?
There is a certification program to become a certified peer recovery specialist. The city, I think, Andre, you're the DVH, I believe, runs a training program. You may know more about the specifics. There are state criteria that are used also, but in terms of getting the actual training, Andre may know more about the way to do that.
Yeah, they just have to contact DBHIDS or any local, state, and health organization in that community. Delaware County has one, Bucks County has one, and Montgomery County has one. And they'll give you a lineup of when trainings take place. They now are part of a Pennsylvania Certification Board. So they have now joined the Pennsylvania Certification Board. So basically when you contact them, it's a 2-week training, 1 week on, 1 week off. And you have to, requirement to have lived even substance use disorder, mental health disorder, co-occurring disorder with records of having one. I know that's for certified peer specialists. Certified recovery specialists can be anyone, a family member, friend, anyone who wants to, commit their life to providing services from a lived experience approach. Because these are all lived experience peer culture approaches towards becoming part of this great world that we provide for addiction services. So
Okay.
let's contact your local health agency in your community, and they will provide you this contact.
One of the statewide programs now that's based in emergency departments across the state expects there to be a peer recovery specialist who can implement the warm handoff, which is really helping guide the person to a treatment program. So it's becoming a more common and more institutionalized role.
Okay, thank you. Andre, this question is for you. How can a behavioral health provider best partner with a peer specialist to share care?
I think the peer would help the provider set up boundaries with the participant. Dr. Metzger just talked about a warm handoff. That connection and that trust has a direct result on retention rates in programs. So you can see a program that has a lively peer culture connection to the participant class or staff or participants who enter the program. And when they have a peer specialist or anyone from the lived experience world, you'll notice that they like to come there and participate with them. So just having that relationship and going back to the warm handoff develops trust. That number one thing that you see as a major support factor with providing services, trust.
Okay, and this question is for all of you. How do you all feel about safe injection sites?
I'll jump into the waters first. So one thing I'll say is this has been effectively done in different parts of the world. This has become a vanguard treatment in Vancouver. It is widely used in Portugal. It is being rolled out in other places. One of the most important things, and I don't want to, I feel like I'm stealing Dr. Metzger's thunder here, but there has not been a documented overdose death at a safe injection site. We can't say that for when people are using in their homes, in a shooting gallery, in the street. So one thing that we can do is it provides a safe place for someone to go, and it allows for casual contact with a peer specialist that's interested in, hey, what's going on with your life, or other health providers, and can then say, hey, if you ever want to talk about making any changes, I'm here. Is there anything else I could work with you on in your life that we can do? And it starts that relationship that can then open up to change when someone is ready.
I would agree. And I always, when people ask me this question, I always say, how do you feel about unsafe injection sites, which we have thousands of them in the city? People overdose in the bathrooms at McDonald's or Popeyes on Broad Street. And, as Travis said, for me, the biggest advantage of these is that they bring people into contact with people who can genuinely provide some help. And so I think the more venues, the more programs we have that bring users into contact with people who genuinely want to help them, the better.
Oh, I agree with Dr. Messer and Dr. Cause. We would never see these people. That's why they were living in encampments. If you remember before the encampments came because of the train tracks. If you remember Conrail, they lived down beside the train tracks. When they moved them out the train tracks, they went to underpass. So people in that world really stay in a 4-block radius and can stay in that 4-block radius for years, in and out of shooting galleries, never coming in contact with anybody that can get them out. As I said during my training, when I went down to the encampments and office services, a lot of them accepted them. So bringing them into these safe injection sites is not only about providing safety and care to saving their life. Again, to Dr. Messer and Dr. Cause, is a connection with that peer specialist that can provide not the first time they come through, but that bad day when things are not going well and they come in there and they finally ready. Because one thing you got to know, you can go out there and offer people help all you want. If they're not ready, you know, so it's basically like just being there when that person is ready, being on site, being present when that person is ready. And another thing, you know, you got to save their lives. You got a 22-year-old kid ready to go shoot dope right now, excuse my language, inject heroin right now. Why not give him an opportunity to save his life? Because 10 years from now, he might turn his whole life around. 2 years from now, he might turn his whole life. The next day, he might turn his life around. So we have to, you know, I hear people say all the time, well, they don't need to die because they shooting. They're not trying to die. They're just trying to get high. So why can't we go above and beyond to provide them services that we can save their life? We can't do nothing with their drug addiction until they're ready. We can provide the services. We provide help. That's what we do. So I think from that place, we have to provide the help to them.
And one thing I would quickly add, just real fast, is there's a hole and not in my backyard. I don't want that near me. That might increase crime. That might include loitering or other influences. But if we spread that wealth and share that across a community and have multiple access points, just like we do with making medication-assisted treatment in primary care and other places people may go, then it becomes a, hey, there's support anywhere. You don't have to travel just to this area and a bunch of people are here, but they can go in their community to get care and be able to travel back and forth between where they need to be.
Thank you, panel. This was an extraordinary evening, especially given, you know, all of the distractions and the ways that our attentions are divided these days. We really, really appreciate this. And to our audience, we also want to let you know that that our panelists have agreed to So as folks are finishing their post-test, I want to say thank you all so much for attending this evening. If you're one of our community partners, please consider joining us on Monday, February 1st, for our next training event entitled Ethics and Integrated Care. If you're interested in getting a PDF copy of the PowerPoint presentation, please reach out to someone on our team, Wendy or Fatima. If you know of someone who would like to view the video recording, please also reach out to a member of our team and we will make it happen. So just FYI, Wendy, would you like to say anything else about some of the particulars about getting access to the slides or the video?
Sure. I mean, it's just a repeat of what you said. Please, you know, you can email Fatima or me, and after we get everything edited, we add you to some mailing lists. And like, I have a mailing list for those who want the PDF of the slideshow, and I have a mailing list to those who want to see the video when it's posted on our YouTube channel. So just let me know, and I will add you to those mailing lists. And then when they're posted and ready to go, you'll get a copy of them. Also, if you have any questions, please feel free to email Fatima or me, and we will get them together for this follow-up interview video, and we'll put you on a mailing list to make sure we let you know when that's been posted as well.
Thank you, Wendy. So that really concludes our training event.